Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
For those of you who would like to know more about what happens to your eyes, especially as you age, I've got an expert, Dr. Dan Georgescu. And Dr. Dan, we call him, he's an ophthalmologist at Browaed Health North. Thank you for talking with us today, Dr. Dan.
Good afternoon. Thank you for having me.
You have great credentials. I was looking at pages and pages of research and things that you've done. And so you're just not a typical ophthalmologist, are you?
No, I'm actually an oculofacial plastic surgeon, and that's a subspecialty of ophthalmology. So today we have 8 subspecialties in ophthalmology, and we have to subspecialize to be competent in each one of these individual fields. And mine is oculofacial plastic surgery, which deals with the functional, the reconstructive, and cosmetic surgery of the eyes, the eyelid, the face, the orbit, the eye socket, and the tearing system.
So you're not the person who's going to do the cataract surgery. You're going to do other kinds of things, it sounds like to me.
Yes.
Okay, so if I were a patient, what would I come in to see you for?
So again,
Typically.
my specialty deals with the eyelids. So any eyelid problems such as droopy eyelids, tearing, dry eyes, anything cosmetic on the face, that would be my specialty. Again, all the problems involving the eye socket, which is the cavity where the eye sits, which can be a tumor, can be bulgy eyes from Graves' disease, can be trauma. That also is treated by me. So any tearing problem, any blocked tear duct, that's another field that I deal with. But I would say the majority of my patients come in with eyelid and facial problems.
I see. So, but they're serious. It sounds like, is this something that happens in an accident, or this happens as one ages? How does that do?
It's both. Sometimes can be due to accidents. Sometimes, the most common scenario is aging, and or call it involutional. But it's aging, it's gravity, and sometimes it's allergies. People rub their eyes, their eyelids get loose, get droopy, and that can be fixed, especially if the eyes are blocking their vision or their visual field, and they can have impaired driving or reading. That's something that insurance companies cover. Sometimes it's cosmetic, and it's something that the patient can elect or not to have it fixed.
Now, do these services and what you do, your medical services, happen in a hospital, or is that outpatient? How serious are they?
Yeah, so most of them are done in the surgery center in an ambulatory setting, so day surgery. Some can be done in the office, and sometimes you have to go to the hospital. Even though most patients don't stay overnight, depending on their other medical conditions, some of these procedures have to be done in the hospital.
And the one thing that I think people should do, and it's part of, what I always tell people as a gerontologist, when you go and have any kind of operation, surgery, no matter how simple it is, bring someone with you, an advocate. You don't want to drive and go home, or even if you can drive, it's not a good idea, correct?
Absolutely. Yeah, we actually have that as a requirement. So all of our patients need a driver, and they cannot be by themselves the day of surgery.
That's excellent. So what is the most common problem that you see?
I would say the most common problem that I see is droopy eyelids, and that is due to aging, and could be allergies, could be constitutional. There are patients, people that have droopy eyelids, they've always had droopy eyelids, and with time, because of gravity, that gets worse. And sometimes this problem can affect their vision, in which case it's covered by insurance. Sometimes it's purely cosmetic. So anything that blocks vision, that affects the reading, the driving, it's considered a medical condition, and it is covered by insurance. Anything that's not affecting vision, such as bags or loose, hanging skin, is cosmetic.
So when you say droopy eyelids, then they can't probably see so well. I mean, it isn't just cosmetic, is it?
Well, again, if it is blocking the vision, and that happens quite often, insurance usually will cover the procedure, which can be a ptosis repair, where the muscle that lifts the eyelid is tightened, or a blepharoplasty, where the skin that's hanging over the lash and is blocking the vision is removed. If the vision is not affected, then it's considered cosmetic, and insurance doesn't cover it.
So when you first went to medical school, why did you decide to become an ophthalmologist with all the other specialties available?
Well, it's a long journey. I was in school for 17 years before I started doing what I do today. I got my first job when I was 35, and that's because medical school is long. So I actually did medical school and a PhD in neuroscience afterwards, which has a lot of things in common with ophthalmology, and that's where I really discovered ophthalmology, and I decided to become an ophthalmologist. And then, as an ophthalmologist, I had to choose between the 8 subspecialties because I wanted to be really good at what I do, and that's how I found oculofacial plastic surgery, which is one of the most, let's say, sought after specialties in ophthalmology, and I trained during my 2-year fellowship with Dr. Rick Anderson in Salt Lake City, who is one of the grandfathers of oculofacial plastic surgery in the States, and that's how I became an oculofacial plastic surgeon.
I see. So it's been a long road for you. I see that. So tell me what has occurred in technology from when you first started doing this and what you do now. I mean, are there robots involved?
Well, I would say not really robots, but everything is microsurgery. We have a lot of lasers, a lot of microscopes, a lot of fine tools that we use to achieve, the results we're able to achieve today. One thing that has happened recently, actually in the past year, is that we have a new technique, a new surgery for patients who have lost their corneal sensation. And that happens very common. Actually, it's more common than we think. And it actually is very common in patients who also have facial palsy. And that's a big health issue because patients can lose their vision. And patients who lose corneal sensation, who don't know that the eye gets dry, they don't blink, they don't protect their eye, so the eye can actually get scarred, and they can permanently lose their vision. And until recently, we didn't have any good options. I mean, we had treatments for facial palsy, which commonly occurs at the same time because the trigeminal nerves that innervate the cornea and the facial nerve, they can be part of the same disease process in the brain, whether it's a tumor, or it's a stroke, an aneurysm, trauma, sometimes a viral infection. They can both be affected at the same time, and patients get facial palsy, which we know how to treat. We've been treating that for a long time. We can do facial reanimation. We can transfer muscles and nerves in order to allow the patient to move the face again and close the eyes and move the lower face. However, until recently, I mean the past couple of years, we didn't have any good option for the treatment of the loss of corneal sensation, or the neurotrophic keratopathy, it's called. And the problem with this is, again, we can reanimate the face. The patients can blink, but they don't know they have to blink. So for these patients, we have developed a new technique called corneal neurotization. So we transfer a nerve, a sensory nerve, from the forehead to the cornea so they can feel again. And this is very important, not just because the nerve allows the patients to feel that the eye is irritated, dried, or something in it, but also the nerve has growth factors that feed basically the cornea, the surface of the eye. And without these growth factors, the cornea becomes opaque. They lose their vision. And we have a new technique called endoscopic corneal neurotization, which was actually developed by a friend of mine, a colleague from Duke University, Dr. Ilya Lengold, a couple of years ago. And I started using this technique a year ago with amazing results. Patients that had basically completely lost their vision. They were hand motion or light perception, so they were technically blind in one or both eyes. They were able to regain their vision almost near driving vision. And most of these patients were able to have a corneal transplant so they could regain their vision completely. And this is to me, this is a huge breakthrough in what we do, because till recently, we didn't have an option for these patients. And there are a lot of patients that suffer from this problem, and probably they're not aware that now we have a treatment for it.
Oh, absolutely. This is all new for me. I haven't heard about this before. I'm so glad that you're on our show, Dr. Dan, to talk about this. So, Dr. Dan, you can be reached. Now, the number I have for you to be reached is 954-991-8200. Does that make sense?
That is correct. That is my office in Fort Lauderdale. Yes.
Okay, and so Dr. Dan is talking about he's not an ophthalmologist that you would go to for cataracts. He has a very specialized procedure that you've been listening to, and it's interesting to talk with you, because I think when people have plastic surgery, sometimes the eyes don't get it right. I have to say that.
Yes, it is true. Unfortunately, I still see a lot of patients that had plastic surgery in the past, and they can close their eyes, the eyes don't function properly. And it's very important when we do surgery of the eyelids especially, but the entire face, to make sure those eyelids not only look better, but also function better. Because the eyelids move, they have a very important role, which is protecting the eye and functioning as windshield wipers. And if the eyelids don't close, if they don't move properly after the surgery, the vision is impaired. Yeah, the result could be good, aesthetically speaking, but from a functional standpoint, it could be a huge impact on the patient's vision. So any cosmetic surgery actually has to be cosmetic and reconstructive at the same time. And most patients that actually are seeking improvement with surgery, cosmetic improvement, they also have all the aging changes that are typical for the eyelids, like droopiness, laxity, sometimes ectropion, eyelids turn out or turn in. And those have to be addressed at the same time with their cosmetic portion of the surgery, because those eyelids have to function better, not just look better, they have to function better after the surgery. Same thing happens with the lower face, the brows, the cheeks. All these aesthetic units, they have to function better and look better at the same time.
So do plastic surgeons bring you in at the time that they're doing this, or is this after or before?
No, basically, I'm a plastic surgeon of the face, okay? They're plastic surgeons that do the body or other parts of the body, right? So each one of us has to be aware of the role, of the functional role of the body part that they operate on. So when I'm talking about reconstruction, this can be after surgery, after prior surgery done elsewhere, or it can be patients who suffer the aging changes, the evolutional changes, the gravitational changes, if you want to call them that way, that are normal. And all these changes can be fixed, can be improved at the same time with their cosmetic part of the surgery.
Well, the one thing that I have to really say, though, about all this is that the big problem that people do is they don't go to the people who are qualified, and that's a real mistake. You see, I've heard a lot about that. You have to go to people who have credentials such as yours don't go. I mean, people go across the world. They go because they're concerned with money. And many times, as you probably know, because you have to do redos, they get in trouble.
Unfortunately, yeah, it happens more often than not, and especially where we live, it happens a lot. A lot of patients travel abroad, especially in South America, and they can get certainly same or similar procedure for less money, and I do see a lot of complications, especially coming from that part of the world. But I think it's very important for us as doctors to subspecialize and be really competent in what we do in our field, and that's why in ophthalmology we have now 8 subspecialties because it's impossible to do all of them well, to be good and be the best in all of them. It's not possible anymore. That's why about 25, 30 years ago, ophthalmology started having subspecialties, so we can actually be competent and improve and be the best at what we do.
Right. You see, and I didn't know there are so many subspecialties. I think that's absolutely fabulous that you're able to, and you've chosen one of them, I guess, and then
Yes.
And then we have people that do different things. So what are all the subspecialties of your eyes?
So the other subspecialties in ophthalmology are retina, glaucoma, cornea and refractive surgery, pediatric ophthalmology, neuro-ophthalmology, uveitis. All right, what am I missing? So oculofacial plastic is one of them. So there should be 8 in total, but there are many subspecialties, and again, that's because the eye is very complex, and you can't treat everything anymore. Okay, I mean, imagine 50 years ago, ophthalmology was combined with ENT. There was one specialty.
Yes.
There was ENT ophthalmology. Probably was 80 years ago, not 50, but before the Second World War, for sure, there was only one specialty. There was ENT and ophthalmology. And
Right.
probably 50 years prior, there were surgeons and regular doctors. So medicine has definitely evolved a lot and continues to evolve. Now in my specialty, I have colleagues that do only cosmetic surgery, colleagues that do only lacrimal surgery, and colleagues that do only orbit surgery. And I think that's good. That's probably, a good thing. But again, for me, the diversity that I have within my subspecialty, it is exciting, and I like doing orbit and eyelids and lacrimal and the face, cosmetic surgery of the face, because I think they're all related. And you can't do 100% cosmetic surgery or 100% functional surgery. There's always a mix. There's always a mix between functional and cosmetic, and the fine line is sometimes defined by the insurance companies. They say, well, we're going to pay for this because we think it's more functional than cosmetic, or no, we're not going to pay. It's more cosmetic than functional.
Yeah.
But again, I think especially with the eyelids are a very good example because they have a major role in protecting the eye and in providing vision and ensuring that the patient's vision is protected. And if we don't take that into consideration, we do any aesthetic cosmetic surgery of the eyelids, the patient can have dry eyes, they don't close their eyes, they can lose vision. So all that is very important to have in consideration.
And when people have strokes, I do notice that they do have a lot of disfiguring. That's not probably something you can deal with, is it?
Yes. You mean strokes?
Yes, they have a stroke.
Yes. Yeah, so facial paralysis can happen after a stroke, and I do all the reconstructive surgery for the patients that cannot close their eye, cannot move their faces, and that can be significantly improved. All the procedural facial reanimation that we do today are very effective, and we can absolutely help those patients. Fortunately, after a stroke, most patients recover their facial nerve function. But there are cases when we don't, and after basically 6 months to a year of no improvement, we have to intervene surgically and repair the problems. But in the interval between the stroke or the accident or the, let's say they have a Bell's palsy, we have to make sure that the eyes were protected and there's no damage to the cornea, the vision, while the patient is recovering. And if there's no recovery beyond the 6 months, then yes, we can do the reconstruction to reanimate the face.
That's very, very good news. So how long, when you do, what's the simplest operation you do? How long does it take to, be that the patient it can go on their way? And what's the most serious one?
Sure. I mean, the shortest surgery would be a ptosis or an ectropion surgery, which takes anywhere between 15 and 20 minutes. And can be done in the office with some local anesthesia, or it can be done in the surgery center with light sedation. The longest surgery can take hours if there's a big reconstruction, a facial reanimation, a facelift takes a couple of hours. Orbital surgery can take between an hour and a couple of hours, depending on what we're dealing with. But most, and I mean 99% of my patients go home after the procedure. The only time when I have to keep them in the hospital is if there are other underlying pathology, other underlying conditions that require medical attention after the surgery. So we have to keep them overnight in the hospital.
I see. That was my question. So it's always better to do that and make sure that you're okay, because that gets into some serious consequences otherwise.
Of course.
And you're very good at that. Well, let's. I want to just go back over this a minute, because I want everyone to know who we're listening to. You really are so brilliant. I've not really had anybody in this field, as a matter of fact. I've had lots of ophthalmologists, and that's what I guess when someone asks you what you do, but you probably then also say that it's called oculofacial plastic?
That's correct. Oculofacial plastic surgery.
Yeah, right. I see that. So that's, and I really am very pleased that we have someone like you working with one of my favorite hospitals, which is, of course, Browaed Health North. Is there a big surgery center there for vision now?
It actually is. We were able to have an ophthalmology service, and this has happened in the past, I would say, year to year and a half. So now we have all the subspecialties, and I have very competent and very good colleagues, ophthalmology colleagues here at Browaed North. Obviously, all the other specialties in medicine are covered, but yes, in ophthalmology we have pretty much all the subspecialties, and we are expanding. We're hoping to have residents join us for training, and obviously do research and other academic activities at the Browaed Health North.
I see. Yeah. Well, I happen to be on the Browaed Health Foundation board, so I'm always so happy to hear people like you, that you're such a valuable part of, what people think of as why they go to hospitals. There's a lot of problems with people who live in areas and they don't even know what their hospital does. And I have to tell you, you can take a tour of this hospital and see it's under a lot of reconstruction with things. I think, isn't it the emergency center that has now been totally revamped?
It is the most modern emergency room in the state of Florida, and the entire hospital actually has been renovated. Everything is brand new. We have brand new ORs, and the newest ORs in Florida, operating rooms, the newest operating rooms in Florida, the newest ER. So absolutely. It is everything is state of the art. We have a robot. We have a lot of
robots.
A lot of tools that the robot doesn't apply to my field, but my general surgery colleagues definitely use it all the time. So we have a lot of good technology at Browaed Health.
Yes, I know you do. Do you? So I don't. Did I ask you that? I know you you started out Neuroscience. So are you sorry you didn't stay with that?
Well, neuroscience, it's a research field, and I was an MD PhD student, so I did 5 years of research, basic science research in the field of neuroscience, which I continued during my residency and fellowship. I still do a lot of clinical research. I don't do basic science research because I don't have the time, and I believe you really should be, the best at what you do, and it's virtually impossible to do basic science research and be a good surgeon at the same time.
Right, but
because you have. Yeah.
When I see, though, the papers that you've written, if anyone should be getting a Nobel Prize, it seems like you should. When do you have time to do all this? I can't believe this.
Definitely a Nobel Prize involves a lot more work and a lot more time than I spent in basic research. But I definitely was very fortunate to work with some of the best, and actually with some Nobel Prize laureates when I was at Yale.
I wasn't too far wrong, was I?
But in order to get a Nobel Prize, it's a lot more work than that. It's a lifetime, dedication to your field and a lot of work.
Well, Dr. Dan, it has been a great pleasure. Thank you for doing this, and we're going to get you on YouTube, and then hopefully I'll talk to you again soon.
Thank you for having me.
Yes.
Now it's been a real pleasure.
It's been a great pleasure for me. Thank you again.